So thank you all for joining us this evening. This is our inaugural cholesterol masterclass. This is the first of 4 sessions. We'll go into a little more detail here, but I just want to start off with a couple of housekeeping things. My name is Eric Trico. I am a care navigator here at the Family Heart Foundation, and we'll be joined today by Dr. Mary McGowan, who is our Chief Medical Officer as well. Next slide. So just as a reminder, this information that we're going to be presenting today is specifically for education. It's not intended to be a substitute for medical advice, getting a diagnosis or treatment specific to you. This does not constitute medical or other professional advice. Medical information is also changing, so information in this webinar, while up to date right now, could change in the future. And we always want you to be thinking about following up with your doctor and your medical team for specific recommendations for your care. Next slide. A couple of things here. So we encourage you all to introduce yourselves in the chat. At the bottom of your screen, there's that chat function. If you have that selected to everybody, give us a little introduction of where you're joining us from and who you are. And we'll be sure to introduce ourselves as well. Next slide. At the end here, we've built in a lot of time for Q&A, so you can add questions into the chat and we'll address those at the end. You can also use the raise hand feature and we'll call on you if you'd prefer to just ask your question in real time at the end. Next slide. You can also adjust your view if you want to see who's talking or everybody that is in the room here. Feel free to keep your video on or off. Next slide. And we would like to thank our sponsor, Amgen, who is the sponsor who made this cholesterol masterclass series possible. Next slide. So a quick overview, and we'll go into more detail here. So I'll give a quick background in who we are here at the Family Heart Foundation. We'll talk about the overall goals for the cholesterol masterclass and then get into a little bit of a breakdown of the structure of the class for today. Next slide. So for those of you who may not be familiar with us, the Family Heart Foundation, we are a nonprofit organization, and our goal is to save generations of families from heart disease through timely identification and improved care of familial hypercholesterolemia, FH, or elevated Lp(a). We have many different efforts through research, advocacy, and education where we're really trying to empower families to be able to better navigate their own health. While we normally work with people with inherited cholesterol disorders like familial hypercholesterolemia and high Lp(a), today is going to be a little bit different. So this is not specific to people with inherited forms of cholesterol disorders. This is for anybody trying to get a handle on their cholesterol. The class is broken out into 4 different sessions. We'll be meeting this week and the following 2 weeks, and then the last Wednesday of the month. Today, we're really going to be talking all about cholesterol and how it's related to your heart health. So this is kind of the basics of understanding lipid testing, your lipid profile, and how that's related to atherosclerotic cardiovascular disease. Next slide. And before we dive in, one of the things we want to do here is just to kind of get your mind thinking about some of the topics we'll be discussing today. This isn't meant to be a test, but just kind of get some background information on kind of where people are at as far as their knowledge about cholesterol. So I'm going to launch a poll here. This first question is, when you have too much cholesterol over time, blank can build up in your arteries and make it hard for blood to flow to your heart and brain. Give me just a moment to launch this poll. You should see the options popping up, the options being red blood cells, white blood cells, plaque, or platelets. And I'll give about 30 seconds, and then we'll take a look at what the answers are. Okay, I think we got most of the answers here. So share the results. So plaque is correct. Plaque does build up in the arteries, and we'll go into more detail about that process shortly here. But we will go to our next question, which is, we have two main types of blood cholesterol. Which type is commonly referred to as the good cholesterol? Launch that. So the answers are HDL, LDL, triglycerides, or type 2. Right. So looks like most people got that right. HDL is what has traditionally been referred to as the good cholesterol. Our next question is, people with high blood cholesterol have about blank the risk for heart disease that people with ideal levels have. So either the same, twice, 3 times, or 4 times. Okay, we got most of our answers here. So the correct answer to this is twice the risk for heart disease compared to people that have ideal levels of cholesterol. This does come with a little bit of a caveat. So for people with inherited forms of high cholesterol, like familial hypercholesterolemia, that risk might be higher. But for kind of the general population, having high cholesterol leads you to having twice the risk for heart disease compared to people with cholesterol levels in range. And next question is, most adults need to have their cholesterol checked how often? Right? So the answer to this one is actually every 4 to 6 years, adults should have their cholesterol checked. For people that have high cholesterol that require treatment, that might be more frequently. But for healthy individuals, the usual recommendation is every 4 to 6 years. But again, unique situations might make that more frequent. And our last question here is, your cholesterol levels are affected by which of the following? Watch that. Oh, hold on just a second. So how much physical activity you get, unhealthy diet, your genes, or all of the above. Great. Quick on that one. As you all guessed, it is all of the above. All right, so let me go ahead and close this out. And we'll go to the next slide. And at this point, I will hand it off to our Chief Medical Officer here at the Family Heart Foundation, Dr. Mary McGowan, who has also been practicing in the cholesterol treatment space for many years at Dartmouth. So thank you so much, Mary, for joining us.
Thank you, Eric. And it's great to have so many participants, and I'm sure there's some of our advocates here today. But for people who are just joining us for the first time, welcome to the Family Heart Foundation. And today I'm going to talk about cholesterol in your heart health. And we've already finished our baseline quiz. And this is the outline that I'd like to cover. You know, what's your cholesterol? What is your lipid panel composed of? And ask the question, what are lipoproteins? What's lipoprotein little a? And we'll ask about the added risk associated with lipoprotein little a. We'll talk about lipid goals for people with atherosclerotic cardiovascular disease, which we often refer to as ASCVD, or people without ASCVD. We'll ask how LP little a is measured and what constitutes a high level. And then we'll talk about atherosclerosis and what causes it. So I think this is a really simplified view of thinking about cholesterol. And many of you have probably heard this when you went to the doctor's office. HDL is your quote unquote happy cholesterol for H, and the LDL is your lousy cholesterol for the L. But you're all here to take a much deeper dive into lipids and lipoproteins. And so I want to really go through those with you. And by the time we're done, you'll probably know more than your doctor or your healthcare provider. So what is cholesterol? And cholesterol is a waxy fat-like substance, and it's not soluble in blood. So it needs to be carried throughout the body. And the way it's carried throughout the body is in lipoproteins. And I'll show you a picture of these. You know, we need some cholesterol. We need it to produce hormones, vitamin D, and our cell membranes. And for the average person, 75% of the cholesterol in their bloodstream is produced by their body, principally the liver, and 25% or so comes from the diet. When we think about lipoproteins, LDL, HDL, and lipoprotein little a, which is a lipoprotein many of you may not have heard of yet, but we're going to get into it. LDL, HDL, and lipoprotein little a all contain significant amounts of cholesterol. And LDL and LP little a tend to carry their cholesterol into the arteries and to deposit it in the arteries, whereas HDL carries cholesterol back from the liver for processing. So all lipoproteins contain the same things. They all contain apolipoproteins. They contain cholesterol, both free and chemically modified, esterified. They all contain triglycerides, and they all contain phospholipids. But they all contain these in different quantities. So here you can see, this says this is HDL. It stands for high density lipoprotein. This is LDL, low density lipoprotein. This cartoon is what's called middle density lipoprotein. I like to refer to this as IDL, intermediate density lipoprotein, and that's what it's typically called. VLDL is very low density lipoprotein, and chylomicrons are a sort of a little bit of a version of VLDL, but it's the dietary version. So LDL and HDL, these two are very rich in cholesterol. So you can have free cholesterol in the core of a lipoprotein or on the surface as cholesterol ester. Free cholesterol is really what we call hydrophobic, doesn't like to be near the blood. So it's in the core. And so HDL and LDL contain a fair amount of cholesterol. VLDL, very low density lipoprotein, has 5 times as much triglyceride as cholesterol. So VLDL is a lipoprotein that's actually produced by the liver. It's one of the main lipoproteins produced by the liver. And VLDL goes out into the bloodstream, and triglycerides are removed from the VLDL. It gets converted first to medium density lipoprotein, or IDL, intermediate density lipoprotein, and then it gets converted to LDL. Chylomicrons are what we produce in our intestines to package up the cholesterol and triglycerides that we eat. Chylomicrons contain 10 times as much triglyceride as cholesterol in the core. So when you get your lipid profile back, you get a total cholesterol, you get triglycerides, you get HDL and LDL. And if you were to add up LDL, HDL, and triglycerides, it doesn't add up to your total cholesterol. So what's the formula? The formula is called the Fried-Wall equation. And your total cholesterol then can be calculated by adding together your LDL, your HDL, and 20% of your triglycerides. Triglycerides divided by 5. So your total cholesterol is equal to the LDL plus the HDL cholesterol plus triglycerides divided by 5. And you can use this formula as long as your triglycerides are less than 400. And it's most accurate when the triglycerides are less than 250. Now remember, VLDL contains 5 times as much triglyceride as cholesterol. And when you wake up and you have a fasting lipid profile, all the triglycerides that are seen in your lipid profile are really from VLDL. So remember, VLDL contains 5 times as much triglyceride as cholesterol. Therefore, and I'm going to show you an example, if you divide your triglycerides by 5, you get the amount of cholesterol in your VLDL. And it's important to know that you should be looking at every component of your lipid panel, because you can have a normal total cholesterol, still have a high LDL or very high triglycerides, or certainly a low HDL, low protective cholesterol. So here's a couple of examples. Remember, LDL plus HDL cholesterol, triglycerides divided by 5 equal your total cholesterol. So here's our first example. Somebody has a total cholesterol of 250. They have an LDL of 170, which, as we'll find out, is too high, an HDL that's normal at 55, and triglycerides that are in the normal range, but sort of in the high normal range. So we are going to say 170 plus 55 plus 125 divided by 5, which equals 25. That equals 250. This next example is actually of a person that I saw in my clinic last Friday afternoon. This was her cholesterol in 2012. Total cholesterol of 364, an LDL of 240, an HDL of 104, and triglycerides of 100. So again, 240 plus 104 plus 100 divided by 5 equals 364. That 100 divided by 5 is 20. So it's 240 plus 104 plus 20 equals 364. One of the things that this person was seeing me for is that she had a heart attack. And she was seeing me, and she told me that back in 2012, and I'm wondering if some people might have had this experience before, her doctor, who was a very good primary care doctor, said, oh, we don't have to worry about your LDL, this really high LDL. I'll just give you a insight into what we're going to talk about later. The ideal LDL for people who have not yet had a cardiac event is an LDL less than 100. So her doctor said, but 364 divided by 104, that total cholesterol to HDL ratio, I bet some of you have heard about that. Your total to HDL ratio is 3.5. That's fine. We don't need to worry about your LDL of 240. And then a few years later, she had a heart attack. So we no longer think about ratios. You can have an excellent HDL, but that doesn't make up for a really high LDL. So that's important to remember. So now let's talk a little bit about LDL. So LDL is a lipoprotein that carries cholesterol in the blood to various tissues, carries it to the adrenal glands and the sex organs so that you can make hormones, carries it to the muscle, and it deposits in the adipose tissue, in the fat tissue. When LDL's job is done, it returns to the liver for recycling. It finds the LDL receptor. But if the recycling is impaired because the LDL receptors are not normal, or if we simply have too much LDL, it can build up in our arteries and cause heart attacks and strokes. So when it builds up, it's called plaque, just as we talked about in the quiz. LDL is recognized by the liver by an apolipoprotein on its surface. LDL is unique. It only has a single apolipoprotein. And if it has a malfunctioning apolipoprotein, ApoB100 is what it's called, the LDL receptor can't recognize it. So it's really important that the LDL has this ApoB100. A person's LDL level is determined both by their diet and by genetics. What raises LDL? Well, saturated fat raises LDL, and to a lesser extent, even though that's sort of counterintuitive, you would think, oh, if I eat cholesterol, that's going to raise my cholesterol. And in fact, that's true, but it's saturated fat that's the biggest culprit. And so what does saturated fat do that causes us to have a higher LDL? Well, saturated fat reduces the number of LDL receptors a person has on their liver cells so that they can't remove the LDL effectively. And the LDL remains in the blood and can find its way into the artery walls. We also know that excess calories and weight gain causes an increase in LDL. Certain genetic conditions, for example, familial hypercholesterolemia, which we at the Family Heart Foundation are very concerned about. And there are other kinds of genetic cholesterol abnormalities. Something called familial combined hyperlipidemia is another form. And there are actually some medications that can raise LDL. Diuretics, like hydrochlorothiazide, steroids. So sometimes people require steroids for prolonged periods of time for things like rheumatological disorders. And that can impact the cholesterol. If you require steroids for a week, like a Medrol dose pack for somebody who's had poison ivy, that's not going to do much. Protease inhibitors, which used to be the mainstay for HIV. We do have alternatives now, but protease inhibitors can raise LDL cholesterol. And then this retinoids are typically used in teens and maybe people in their young 20s for cystic acne or Accutane. And Accutane can increase the LDL, can increase the triglycerides and lower the HDL. So it is really problematic in terms of what it does to the lipids. Generally speaking, people are on Accutane for short periods of time, like maybe a year, but it is a drug that when it is being used, clinicians will be checking individuals to make sure that their lipids haven't gone up. And then there's some medical conditions. In fact, when we see somebody with really high cholesterol, we say we should rule out secondary causes of hyperlipidemia. So hypothyroidism. And I would, there's a little caveat here. Hypothyroidism can certainly raise LDL cholesterol, but generally speaking, when people are mildly hypothyroid, we don't see a huge bump in LDL cholesterol. It's people who are profoundly hypothyroid where we'll see a big impact. Nephrotic syndrome, on the other hand, this is a situation where people lose protein in the urine. And as a result, your body tries to make more proteins and it makes a lot of LDL. And so nephrotic syndrome can cause very elevated LDL, as can obstructive liver disease and diabetes to a lesser extent. So those are things that we check if we see somebody with very high cholesterol. Before we say it's genetic, before we put them on a drug, we want to check those things. So what lowers LDL? Well, diets low in saturated fat and cholesterol. And just a plug for Mary Card's talk next week. She has a really exciting lecture planned for everybody on diet. And so she'll tackle that. She'll also tackle what soluble fiber is. So diets rich in soluble fiber will help lower LDL. People who lose weight will get the benefit of their LDL going down. Certainly cholesterol lowering medicines, and I'm going to be talking about those in the third lecture. These are things like statins, ezetimibe, bempedoic acid, and the PCSK9 inhibitors. Other medicines have a side benefit of lowering LDL, estrogen for one. Estrogen has some little negative side effects though too. Estrogen can raise triglycerides. And one of the things that I really wanted to put in here was to tell you about exercise, because when I'm seeing patients in clinic, they often say things to me like, well, my LDL didn't go down because I didn't exercise enough. I just want to really increase my exercise. Exercise really doesn't impact LDL very much unless you're really doing it to a high degree. So in order to get any movement in your LDL, any movement downwards, you need to exercise about 60 minutes a day. And most people who are exercising but just sort of going for a walk, they're not going to see an impact in terms of their LDL with exercise. And so we've had this, what we call evolving paradigm of how low should you go? And how low should you go with LDL to prevent or halt atherosclerosis? And the fact is we have not found the lower limit. And back in my early career in 1994, I remember when the Scandinavian simvastatin survival study, that's right here, we called it the 4S trial. And that trial was it was a landmark trial. It was, it changed the way we viewed statins and what they could do. This study, the Scandinavian simvastatin survival study, took people who had really high cholesterol, like 190, and really high LDL cholesterol, like around 190, and started them on simvastatin or placebo. And this was the first study that showed we could not only reduce cardiac events by using a statin, we could change all-cause mortality. We could reduce all-cause mortality. And that was really a landmark trial. And then people started asking, if you lowered LDL even further, would it be better? And all these other studies that I'm showing you, the CARE, the lipid trial, the heart protection study, Prove It, the Treat to New Targets, Improve It, and Fourier, each one brought the level down even lower by using statins. And then, so these are all statin trials. Treat to New Targets was and Prove It, high intensity statins versus a lower intensity statins. TNT was a high dose of atorvastatin versus low dose of atorvastatin. Then Improve It was the trial that said, okay, if everybody's on a statin in this trial and we add ezetimibe to half the people, do you go down even lower? And yes, it's true. And you reduce cardiovascular events further. And then Fourier was a trial where we could get people's LDL into the teens. People were on background statins plus ezetimibe, and then they either got, in this case, it was evolocumab, which is a PCSK9 inhibitor, and we'll talk about that more in the third talk, or placebo. And many of these people dropped their LDL levels down into the 20s, even teens. So we now know high, back in the Scandinavian simvastatin survival time, back almost 30 years ago, high is bad. An average LDL is not good. Lower is even better. Even lower is even better. And as low as you can possibly go. And what we can say is we haven't found an LDL that's too low. One of the sub-studies done in the Fourier trial was a sub-study looking at, would there be negative effects for the people who got their LDL down really low? And the answer was no. There were no negative effects in terms of, cognition, in terms of liver function abnormalities or muscle function abnormalities or neurological abnormalities. So it was incredibly well tolerated. So we now know you can go very low. Let's talk a little bit about HDL. Now you'll notice HDL, has its phospholipids and free cholesterol ester. It has cholesterol in the core. It has some triglyceride, not that much. But you'll notice, unlike LDL, HDL has lots of apolipoproteins. HDL is actually a donor when it comes to apolipoproteins. The two principal apolipoproteins on HDL are ApoA1 and ApoA2. But HDL also has ApoC, ApoE, and it donates those in the bloodstream to other lipoproteins like VLDL. And we'll talk about that in a minute. So HDL is sometimes called the good cholesterol because in general, higher levels are associated with a lower risk of cardiovascular events. HDL brings excess cholesterol from other areas of the body and returns it to the liver for recycling. So HDL accepts cholesterol from the cells. And HDL goes to the liver, and when it returns for recycling, it has its own receptor. And you do not need to remember this, but it's called the scavenger receptor B1. And that's how HDL drops off its cholesterol. However, having a high HDL is not enough to outweigh the harmful effects of a high LDL. So as I said, when we were talking about my recent patient who had a total cholesterol of 364 and an LDL of 104 and a ratio of 3.5, we don't use that to predict, because that woman had an LDL of 240, and that in and of itself has to be treated. So we don't want to use the total to HDL ratio to predict. I was talking to one of my younger colleagues today, and she said in her training, she's a cardiologist, She had never once heard of total to HDL ratios. And then when she started seeing patients, when they were asking her about it, she was baffled. So it's not being taught anymore in school. So what raises and lowers HDL? So exercise, where I told you exercise doesn't really lower LDL, exercise really can raise HDL. And weight loss. And there's a caveat here, though. And I always tell people who are actively losing weight not to get discouraged if their HDL dips. So as a person is losing weight, actively losing weight, the HDL can dip transiently. But once it's at a stable, they're at a stable lower weight, the HDL tends to increase and will likely exceed the old baseline. So HDL does go up with weight loss. Alcohol will raise HDL, but we don't usually recommend somebody starts drinking alcohol to raise their HDL. If somebody is already, if a woman's having 1 drink a day or a man no more than 2, because alcohol can raise blood pressure, so it has other negative effects. We don't usually recommend, starting up on alcohol to raise their HDL. And certain medications, estrogens, so remember, estrogens can lower LDL, they can raise triglycerides, but they can raise HDL as well. And steroids, while they have other negative effects, steroids can raise HDL. Lack of exercise is associated with a lower HDL. Weight gain is associated with a lower HDL. Trans fats. Now, trans fats have been in some ways diminished from our food supply, and they have to be labeled, but they can be found in some commercially prepared baked goods. And they are a natural component of red meats. So trans fats can lower the HDL. I'm sure Mary Carr will be speaking more about those next week. Smoking is a big one. You haven't seen smoking really be impacting other lipoproteins. The fact is, smoking can cause oxidation of LDL, which is a bad thing. But smoking actually causes a drop in HDL. Smoking can cause the HDL to fall by 5 or 10 milligrams per deciliter. And within a few months of quitting smoking, a person's HDL can go up. So that's a really positive thing that people can get from quitting smoking. And certain medicines can lower HDL. So beta blockers like atenolol can lower HDL, but there are other beta blockers like Pindolol that your doctor may or your healthcare provider may choose to try to protect your HDL. Those other beta blockers don't lower HDL. Protease inhibitors, once again, can lower HDL. They pretty much do everything in the wrong direction. Zyprexa or olanzapine. This is a medication used for schizophrenia. And when it's used for schizophrenia or other mental health issues, it's used chronically, long term. And so it can cause a drop in HDL. It also can cause weight gain and things like that. Zyprexa is also used in an off-label fashion. It was found somehow that it causes people who are getting chemotherapy not to be as nauseous. So it is used in individuals who are getting chemotherapy. But again, just like taking a steroid dose pack, like I talked about before, if you're only on it for a short period of time, it's not going to do anything to your lipids. And then once again, Accutane does everything in the wrong direction. So we're glad that people are not usually on Accutane for a prolonged period of time. Triglycerides are probably the fat in your diet and the fat that you know the least about. Triglycerides are the most common type of fat in your body. Triglycerides come from foods, especially butter, oils, other fats that you eat. Triglycerides from your diet are packaged into chylomicrons in your intestines. So these big lipoproteins, they don't hang around very long. These chylomicrons go around and they drop off the triglycerides to our body's cells, particularly adipose tissue, and we can use it when we need it. So extra calories from both fat and carbohydrates that your body doesn't need right away are stored as triglycerides in the adipose cells or fat cells. And when your body needs energy, like say you go for a really long hike and you don't bring quite enough food, you'll releasing triglycerides from your fat cells. And high triglycerides in your blood can raise your risk of heart disease and stroke. And interestingly, triglycerides, probably not necessarily from chylomicron origin, but triglycerides from VLDL can be found in plaques. So they are part of the plaque. Oops, sorry, I seem to speed forward too fast. And now we're talking about triglycerides found in VLDL. So the triglycerides that you eat get packaged as chylomicrons, but your liver can also make triglycerides. It can make triglycerides from fatty acids and glucose molecules. So triglycerides are a glycerol or a sugar backbone, and then 3 fatty acids. That's why it's called tri. So it could be a saturated fat, a monounsaturated fat that has 1 double bond, or a polyunsaturated fat that has more than 1 double bond. And so your liver can make these, and then your liver has to package them, because you can't just put triglycerides out into the blood. They have to be in a lipoprotein. And the lipoprotein that the liver makes, by and large, is VLDL. And so this, like chylomicrons, is another triglyceride-rich lipoprotein. But remember, chylomicrons have 10 triglyceride particles to 1 cholesterol, and VLDL has 5 to 1. In the morning, when you're fasting, the triglycerides in your blood are almost all from VLDL. The chylomicrons really do not hang around very long. But if we were to check your triglycerides after you ate a big fatty meal, or a meal that had a hot fudge sundae at the end, what we would see is we would see chylomicrons and VLDL. So what raises triglycerides? Being overweight or obese. I should have also added here having, I do have it in there, having diabetes. Overweight or obese, alcohol. And, exercise can counteract some alcohol raising triglycerides. I once had a patient who he wanted to have 2 alcoholic beverages a day. He wanted to have 2 beers when he got home from work. And when he had 2 beers when he got home from work and he wasn't exercising, his triglycerides were far too high. They were well over 300. And when he was running 5 miles a day, his triglycerides were perfect. So we had a pact. He could have his 2 beers, but he couldn't have them on the days he didn't run. Dietary fats will raise triglycerides. Simple carbohydrates like cookies, cakes, pies, ice cream, white potato, white rice, those kinds of things that Mary Carr will be talking about can raise triglycerides. Lack of exercise. And then just again, certain medications, steroids, thiazide diuretics like hydrochlorothiazide, protease inhibitors, estrogen can raise triglycerides, Zyprexa can, and our old friend Accutane. And then certain medical conditions, hypothyroidism, nephrotic syndrome, diabetes, and chronic kidney disease can all raise triglycerides. So what lowers triglycerides? I felt like I needed to put a little lightness in here. Weight loss, alcohol restriction, restricting certain dietary fats and simple carbohydrates, and increasing exercise. But this guy is walking his dog, but he's getting no exercise himself. So he needs to walk the dog in the traditional way, and he needs to eliminate that soda. We're going to move to talk a little bit about lipoprotein a. And I like this picture because it shows you that lipoprotein a is very similar to LDL. So lipoprotein a, like LDL, has this ApoB 100 on its surface, but it also has another apoprotein. It's called apolipoprotein A, or LP(a). And it's important for you to know that lipoprotein a is not included in your standard lipid panel. So you need to request this test. I can tell you that I'm guessing that most people on this call have not had their lipoprotein a measured. And the reason I can guess that is that only 1% of Americans have had their LP(a) tested. Yet, 1 in 5 people in the United States and worldwide have an elevated lipoprotein little a. So 66 million Americans have an elevated LP little a, and only 1% have had their LP little a checked. So most people who have high LP little a are unaware that they have high LP little a. And there are 1.4 billion people worldwide that have a high LP little a. So let's take a little deeper dive into LP little a. This is another schematic. You can see it's got the ApoB100. Also has these little things, these little orange things, and these are called oxidized phospholipids. And oxidized phospholipids are inflammatory, and they're also involved in causing aortic valve stenosis. So people with high LP little a are at increased risk for atherosclerosis and thrombosis, and we'll tackle that in a minute, but also aortic valve disease. And so like LDL, LP little a can get into the artery wall, can cause plaque. So it can cause stenoses or blockages in the artery, blockages in the arteries that cause a heart attack or a myocardial infarction, blockage in the arteries that go to the neck, that are the carotid arteries that could result in a stroke, what we call an ischemic stroke. And this apolipoprotein A sort of mimics a clotting factor. It mimics plasminogen, but it's not active, and as a result, it can inhibit the ability of us to break down clots. So it's sort of a triple whammy. It might inhibit the way breaking down clots. It gets into the artery wall, and it can cause aortic valve stenosis through its oxidized phospholipids. So LP little a is something that everyone should have measured. And people sometimes say, why would I measure LP little a if there are no medicines right now to lower LP little a? And it is true. Currently, we do not have any medicines. We have a procedure called lipoprotein apheresis that can actually remove LP little a from the bloodstream. But it is typically done if somebody has both high LDL and high LP little a. But we do know that if somebody has an LP little a greater than 50 milligrams per deciliter, that's considered high, and we'll get into that again in a moment. There was a study called the Epic Norfolk study, and 14,000 individuals were in it. And what they asked the question was, if the individuals have an LP little a greater than 50, what's the risk if somebody has lots of risk factors plus the high LP little a, or the risk if somebody has very few risk factors plus the high LP little a? So, and the risk factors that they looked at were smoking, overweight, diabetes, high blood pressure, high cholesterol, physical inactivity, and an unhealthy diet. So if somebody had lots of those risk factors, they were the reference. So they were at high risk. And people who had low number of these risk factors had a 66% lower risk of a cardiac event. So if you have high LP little a, it is really important for you to get rid of all your other risk factors. And just a story about one of our Family Heart advocates. The Family Heart Foundation has trained over 180 advocates. And one of our advocates had a heart attack at a very young age because she had a high LP little a. That was her only risk factor. And she said, one of the other benefits of if she had known she had a high LP little a, she said, if I had known I had this high LP little a, which she found out after her heart attack, she said, if I had known I had a high LP little a, I wouldn't have waited 16 hours thinking that my chest pain was a panic attack. So she waited 16 hours before going to the emergency room. And even then, it was only at the insistence of her husband. So knowing that you have a high LP little a gives you information that would make you take all your other risk factors quite seriously. So what are the goals for people with and without atherosclerotic cardiovascular disease? So atherosclerotic cardiovascular disease really encompasses heart disease, people who have had stents, people who have had bypass, people who have had heart attacks, and it encompasses peripheral artery disease, blockage in the legs or arms, and cerebrovascular disease, blockages in the neck or the brain. So that's what ASCVD is. So for people without ASCVD, you can imagine that the cholesterol goals don't have to be quite as strict. So we want the total cholesterol to be less than 200. We want the LDL to be less than 100. For HDL, we want men to have an HDL greater than 40. For women, greater than 50. Women normally have HDL levels that are higher than men. And triglycerides, less than 150, but I would say ideally even lower. And then we have to be stricter with people who've had atherosclerotic cardiovascular disease. We want their LDLs to be really low. We want their total cholesterol to be less than 150. We want their LDL to be less than 70. But recently in 2022, so this is our guideline from our 2018 cholesterol guidelines. But last year in 2022, the American College of Cardiology met and recognized that people who are at very high risk of cardiovascular disease should have their LDL even lower. And we saw that from all of the trials. The lower you got your LDL, the better. And so the recommendation is ideally less than 55. And this was in 2022 that the American College of Cardiology recommended this. We were catching up with our European colleagues who said in 2019 that the level should be less than 55 and even lower is better. And the HDL and triglyceride levels are the same for people with and without atherosclerotic cardiovascular disease. Why is achieving your LDL and keeping it there so important? Well, based on a number of individuals, this is multiple statin studies, 26 statin studies, 170,000 individuals with in a statin study typically lasting 5 years. For every 40 milligrams the LDL fell, the cardiac risk falls by about 20%. And the same formula holds for other medication classes, including ezetimibe, bempedoic acid, and PCSK9 inhibitors. Let's talk a little bit about Lp(a) measurement, and it can be tricky. And you really need to look at the units that it's measured in. So we think that over time, all measurement is going to move to nanomoles per liter, and that is preferable. But for right now, there are some labs that will measure Lp(a) in milligrams per deciliter. And if your lab measures in milligrams per deciliter, just know high is high. So a normal Lp(a), if it's measured in nanomoles per liter, is less than 75 nanomoles per liter. A borderline level is 75 to 125, and high is greater than 125 nanomoles per liter. If your lab is measuring in milligrams per deciliter, less than 30 milligrams per deciliter is normal, 30 to 50 is borderline, and greater than 50 is considered high. The last section of our discussion tonight is about our arteries, about plaque building up, because people have LDLs that are too high, or triglycerides that are too high, or HDL that's problematic, or high Lp(a). So when we're born, our arteries are really normal and clean, and that's how we want them to be. In childhood, people start getting fatty streaks. And we know this from autopsy studies of children. There was a group of studies called the Bogalusa heart studies. And in Bogalusa, they individuals, young adults and children who died, untimely deaths due to accidents typically, were autopsied. And they found that fatty streaks were related to the cholesterol levels that were drawn in these children and young adults before they died. So we can see fatty streaks. And then atherosclerosis is quite messy. Plaque is quite messy. So what's involved? It is fatty streaks, it's cholesterol, it's LDL, and LDL starts it off. So a lot of times when I'm in clinic, people will say to me, LDL is not important. It's all about inflammation. And I agree that atherosclerosis is about inflammation, but it starts with LDL. The LDL gets into the intima, which is the top layer of the artery that's closest to the blood. It gets in there. And then when it gets in there, it gets chemically modified. It gets what's called oxidized. And that LDL, oxidized LDL, causes the cells that line the artery, the endothelial cells, to become really activated. And those activated endothelial cells produce something called adhesion molecules. And all the blood that's out in the bloodstream, the white blood cells get really attracted to these adhesion molecules, and the white blood cells get into the growing plaque. And those white blood cells gobble up the oxidized LDL. They become foam cells. And red blood cells get recruited. And over time, calcium gets deposited in the plaque. And we start seeing inflammatory cells in the plaque. And you get more calcification. And calcification can sometimes stabilize the plaque. But plaques that don't have much calcium in them, like this one right here, can rupture. And when they rupture, the inside of the plaque is exposed to the flowing blood. My pointer here, the flowing blood. And the inside of the plaque and the flowing blood do not get along well. And so you just like a cut, you try to start blocking this off. And so you get platelets and fibrin that causes clots. And so you can get a big fibrin-rich clot here. And if that clot is large and the entire artery is blocked up, you see, you still have the plaque here. The plaque doesn't fill the whole artery. It's the clot on top of it that can fill the whole artery and cause no blood to get beyond wherever this is in the artery, and you have a myocardial infarction or heart attack. Now, this person here might have angina because they have a narrow artery, and when they try to exercise or something, they've got enough blockage that they will develop angina. They won't get enough blood flow through this artery. So if you already have atherosclerosis, it isn't too late. The goal in secondary prevention is to treat all the risk factors, prevent you from having another event. If you have high cholesterol and you haven't had a cardiac event, we call that primary prevention, and we try to get that cholesterol level down. And as we learned in the case of high Lp(a), treating all risk factors aggressively is crucial. So we just saw what are the complications. This is an actual depiction of a ruptured artery or a ruptured plaque. And so you can see the fibrous cap on the top of the plaque that's separates the plaque from the blood area, from the blood flow. And so if you get a thrombus, a clot on top of a ruptured plaque, and it blocks the whole thing up, you're going to have a heart attack. So when a plaque ruptures, as I've said, it exposes the thrombogenic or clot-causing interior of the plaque to the blood, and the blood's role is to form a clot. And this may be more pronounced in the setting of elevated Lp(a) and elevated LDL. So unless that clot can be removed, rupture of an atherosclerotic plaque can trigger this acute thrombosis or clot of a heart artery, leading to the heart attack. And unless this is broken up, if the clot gets broken up, a person may experience chest pain, but not have a heart attack. So as I mentioned earlier, atherosclerosis doesn't just have to be in the heart. Atherosclerosis can occur in any artery bed. And in each case, we can see acute and chronic presentations. Like you can see a stroke that leaves somebody chronically impaired, or someone can have a TIA, a transient ischemic attack, where they recover very quickly. We can have angina, or we can have a heart attack. And you can get it in the thoracic aorta, that's here, that's in your thorax, in the renal arteries, that's here, in the mesenteric arteries. These are arteries that serve your intestines, the abdominal aorta right here, and in the peripheral arteries in your legs and in the arteries going to your brain. So, people who get an intervention like a cardiac bypass or a stent only really are taking care of one or maybe a few arteries at a time. But lowering cholesterol is going to lower the cholesterol in your blood, and it's going to impact all of your arteries. So cholesterol reduction is a really powerful tool. We're done. So we had our baseline quiz. We learned about cholesterol. We learned about what a lipid panel is composed of, and that all lipoproteins are composed of the same things, but in different amounts. We learned about lipoprotein little a, which may have been something that many people didn't know about. We learned about what the added risks associated with lipoprotein little a are, what our lipid goals are, depending on whether we have heart disease or don't, how LP little a is measured, and what causes atherosclerosis. So I hope this has been useful for you.
Thank you so much to everyone for joining us for our first session. We will be meeting again next week at the same time, where another member of our team will be talking about diet and lifestyle and other risk factors related to cholesterol and heart disease. I want to go to the next slide. So just a quick plug for our LDL Safe Zone campaign. It's worth going to check out ldlsafezone.org to kind of get a little more information about understanding cholesterol goals and targets and reducing your risk for heart attack or stroke down the line. Next slide. And the other thing I want to mention, so a lot of this information was very kind of educationally focused. If you need help with anything related to your care, you can reach out to us at the Care Navigation Center, so familyheart.org/care. And we're more than happy to help with helping you find specialists, helping you interpret your personal results, understand what information is out there about treatments, really anything related to your heart health care, we are here for and happy to help guide you through. You can also, on that website, there's a phone number. You can text me, you can email me, and we'll get you any help you might need. Next slide. One other plug is, as a nonprofit, donations are always very much appreciated. If you want to donate to the Family Heart Foundation, you can do that at familyheart.org/donate. And I think that is everything we had today. So again, thank you so much.